Good evening, everyone. I welcome you all for another episode of wonderful webinar on a burning topic of today, what we see as India's fight against lung cancer, screening for brighter future. So today we have as panelists, we have Dr. Jaykumar Mehta from Ahmedabad and Dr. Gayathri Devi from Chennai, Dr. Dinesh Srinivasa from Bengaluru, Dr. Ravi Dosi from Indore. I welcome you all panelists for this wonderful webinar today. And post that, I would want to have a few questions where you can actually give an input about the moving forward in the Indian scenario about the fight against the lung cancer in the Indian perspective. This is Dr. SA Rafi from Hyderabad. Without any delay, I think we would start the program because we are already crossed 8 p.m. The first talk would be by Dr. Jaykumar Mehta. So over to you, Dr. Jaykumar.
So hello all, I'm Dr. Jaykumar Mehta. I work as an interventional pulmonologist at Epic Multi-Speciality Hospital, Ahmedabad and Aksha Pulmocare Bhopal. Thank you so much, Dr. Rafi sir, for the kind introduction. And at the outset, I would like to thank CCI for providing me this opportunity to speak on a very important topic, that is lung cancer, epidemiology and risk factors, and its potential implications of cancer screening. So we do see a lot of patients in our day-to-day practice where we might have thoughts coming across our minds that whether this patient may have malignancy or not. When it comes to lung pathology, tuberculosis and malignancy becomes one of the most important differentials in our routine clinical practice. And then the question arises that how common is the lung cancer? And the answer which I got is from the GloboCan, that is from the WHO website. That if we talk about the absolute numbers, these are data from 2022. These are absolute numbers about the incidence and mortality. And as we can see, that the lung cancer, it is at peak of the incidence and also it's at peak of the mortality. To put it in numbers, around 24.8 lakhs, roughly around 25 lakhs people developed lung cancer in year 2022. And around 18.7 lakh people died because of the lung cancer in that year, which makes them one of the most common and most lethal of the cancers. Again, I will stress this, that lung cancer is a most common cause of cancer-related deaths. And when it comes to in males, when we talk about some gender, so in males, if we talk about age-specific rate, it is second number than the prostate, and in female, it is second number than the breast. So let's highlight that age standardized rate per 1 lakh incidence and mortality. Again, lung cancer peaks in the males in the numbers with around 32.1 per 1 lakh incidence and mortality of around 24.8 per 1 lakh. While in females, it is bit less. If we talk about the incidence, it comes second to the breast. Around 16.2 per 1 lakh is the incidence, and around 9 is the per 1 lakh is the mortality. Hence, with this data, we can implicates that it is more common and more lethal in men than women. And finally, coming to the part of the age. So this is a study from Hungary where they have selectively focused on what age group we should target so that we can have good lung cancer screening candidates. And as you can see, age 50 onwards, the lung cancer incidence rises, and it peaks at around 70 to 79 and then 80 to 89 years of age. In India, the life expectancy is roughly around 70 years. So we can see that 60 to 70 years probably in India will be a good age, and in that age we find many of the patients suffering from the lung cancer, and it has big potential implication when it comes to the lung cancer screening. Coming to the part of different part of the worlds and continents, again, Asia tops in all three: incidence, mortality, and prevalence, with roughly around 63% cases in all the categories, whether it is incidence, mortality, or prevalence. Lung cancer tops in Asia. The reasons can be many because of the tobacco consumption. India and China both are one of the world's top consumer of cigarette and tobacco. And then there is industrialization, and then there is another economic activities which jeopardizes lung health and makes us at risk of development of lung cancer. So in nutshell, it is more common, more prevalent, and most lethal in Asia than the rest of the world. And hence, we need to do something, because lung cancer was not every time like that. Lung cancer was once considered very rare disease. I'm talking about 1930s and 40s, and it was being looked as once in a lifetime oddity. But with the rise of tobacco industry and industrialization, lung cancer rates have rose rapidly. So that in 2024 now it is considered as one of the most common visceral malignancy, and again most common cause of cancer related deaths. And the link from the tobacco consumption, smoking, and lung cancer was from the landmark study from Dole and Hill, where they have studied the mortality of doctors and their smoking habits in 1954. And that was introspection for us as a community, where many of the doctors quit smoking too. So it provided very strong link of causation. So this is a nutshell, in a brief history about cancer itself, that there were documents of Cayman with around 200 possible cancer sightings by the archaeologists. Then around 1500 BC, there were papyruses which described the treatment with the field drill and so on. And it was Hippocrates who coined the term carcinos and carcinomas for the tumors. And 1761 was the year when lung cancer was identified as a distinct disease. And in 1810, there were many types of lung cancer. The characteristic of lung cancer got identified. In 1876 to 1938 was a year where 60 to 80% of miners died from this disease. And they were known as the death pits. As you can see, there is a steady incline in the rate of lung cancers from 1% in 1878 to 14% in 1927. And then in 1929, German physician Fritz Licketh recognized the connection between smoking and lung cancer. In 1940, lung cancer becomes the second most frequent cause of cancer death, stomach cancer being the first. In 1954, as I depicted the study, they found a strong link between the smoking and the lung cancer. And straight coming forwards to 2013, where it is having the highest death toll or the cancer-related deaths. So let us talk about the Indian scenario. What about the India? After looking towards the global trends, India holds around incidence of 80,000 to around 1.2 lakhs cases per year of lung cancers. And this is very important registry. There is a National Cancer Registry, where I have found this data which tells about at what stage we diagnose this. And this was striking for me, that as you can see, both males and females, here is the column of distant metastasis. And as you can see, breast, cervix, head and neck, and stomach all are detected in their locoregional spread, while lung cancer is the one and only one which is detected more in the distant metastasis stage. And that translates to the mortality aspect. Because of the late detection in the distant metastasis stage, the 5-year survival rate is around 4% when it comes to when the disease gets picked up in advanced stage. Well, if it is localized here, we can see there are 5-year survival chances around 54%. And that is very good. This is again a plot which shows that the stage 1 has the highest longevity, 5-year survival, while the stage 4 is the least. And unfortunately, we are detecting cancers in the distant metastasis stage. And because of that, it ranks amongst the topmost cancer-related deaths. Coming to the types that we differentiate lung cancers into small cell and non-small cell lung cancers, small cell lung cancer being around 15%, while the non-small cell lung cancers, they comprises of adenocarcinoma, squamous cell carcinoma, as well as large cell carcinoma. They are roughly around 85% of the cases. Again, there are different other types of tumor, but I'm just talking about the main types of the lung cancer. And adenocarcinoma by far is one of the most common lung cancer, with incidence of around with around 40%, making around 40% of the lung cancers got identified, followed by the squamous cell and then the large cell carcinoma. Then there are certain type of clinical characteristic, radiological characteristics too, that the squamous cell carcinoma, they happen more in the central airways, while the adenocarcinoma, they happen in the periphery of the lung, and that makes it a bit difficult to diagnose adenocarcinoma. But with the good and sophisticated tools, we are going and reaching that. Again, these are driver mutations in one of the most common carcinoma, that is lung adenocarcinoma. And as we see, this is Western data, and which contributes around EGFR mutations of around 15% and 17% around. And roughly it is dependent on the ethnicity. And in India, the EGFR mutation, I was reading about a literature published from the DMH Tata Memorial, and they were talking about 19% to 22% positivity of the EGFR mutation. So these are all the other mutations which we do routine testing, because it has a bigger implication when it comes to treatment selection or the immune therapy selection. Then coming to the causation, as we all know, what causes lung cancer? It smoking, asbestos, secondhand smoke, genetics, radon exposure, as well as environmental factors are the chief causes why we develop lung cancer. And again, if we take the proportion of this, around 83% of this is made by smoking, either active or passive. While asbestos contributes around 6.7%, and others are 6.7%, radiotherapy around 0.8%. In short, cigarette smoking or tobacco smoking remains one of the chief cause for the lung cancer till date. So about 80% of lung cancer occurs in the smoker or those who stopped recently. The risk becomes 60 times greater among habitual heavy smokers compared to the non-smokers. Although cessation of smoking decreases the lung cancer, but it still remains high and never returns to the baseline level. Passive smoking is also considered as the risk for lung cancer development, and it is twice than the non-smokers. So why it happens? Because cigarette smoking has so many different type of harmful chemicals. The smoke contains toluene, ammonia, hexamine, stearic acid, cadmium, butane, acetic acid, methane. As you can see, there are 400 types of carcinogens. And also there is a process of combustion which happens, which denatures the genetic material, and the mutation takes place. Nicotine, however, is a substance which is not considered itself as a carcinogenic, but it is one thing which makes a person addicted to the smoking. And hence it is very important for us to identify that we should eliminate the process of exposure to the carcinogenics as well as process of combustion when we are educating our patients for the smoking cessation. Secondhand smoke, it is very prevalent in the rural India. The secondhand smoke or environmental tobacco smoke contains also human carcinogens for which there is no safety valve. It is estimated that about 3,000 non-smoking adults die of lung cancer as a result of breathing secondhand smoke. And cigars and pipe also increase the smoke, but much less than the smoking cigarettes. Coming to the environmental carcinogens like asbestos, as you can see, there are mainly the people who are involved in the construction work, mainly in the roof business. They are usually exposed to the asbestos. Again, radon is a radioactive gas. It is odorless and tasteless, and it is usually found from the unearthing of the earth crust. So it generates from the earth crust, and then it goes into the inhalation, and then it causes the genetic damage. Coming to the heavy metals like arsenic, like it is used in insecticides, weed killers, rat poison, fungicides, wood preservatives, paints, and leather industry. So the occupation with one is involved becomes very important source of the development of the lung cancers. Again, chromium, which is used in the plating, stainless steel, nickel, which is used in the coils, and these are other heavy metals to expose. When you are exposed to that, they work as carcinogens. And then these are certain activities like mining and drilling and all. When the dust goes into the lungs, when the person is not having personal protective equipment or the gears, at that point of time, it becomes very much hazardous and at a risk of development. Air pollution, particularly polycyclic aromatic hydrocarbons, which is formed from the exhaust due to combustion of the coal, oil, gas, or garbage, and they all can cause and denature the cells and lead to the lung cancer. Again, WHO estimates that around 25% of lung cancer it occurs in never smokers. The cancer commonly occurs in women and mostly adenocarcinomas. And cancers in non-smokers are more likely to have EGFR mutations and never have KRAS mutations. And TP53 mutations are not uncommon but occur less frequently than in smoking-related cases. Some people ask us why I don't smoke, I am not involved in this activity, still I get the lung cancer. It's because of something called genetic predisposition, that we are having genetic markers of that sometimes this mutations happens on its own, and then it leads finally to the development of the lung cancer. Again, lung cancer itself is a risk factor for the second lung cancer. And other diseases like TB, fibrosis, IPF, as well as COPD. COPD particularly combined risk factor for the lung cancer. So they all increase the development of the lung cancer. So then a short note about rationale for screening. So lung cancer is common. It is diagnosed at an advanced stage. Early intervention can clearly save the lives. And with lung cancer, one can more easily identify high-risk cohort, and that would be of appropriate for the screening. And given this fact that lung cancer screening holds very promising results, and because of that, we need to go for lung cancer screening. So what is definition of screening? It can be defined as a systematic testing of individuals who are asymptomatic with respect to some target disease. And the purpose of screening is to prevent, interrupt, or delay the development of the advanced disease in the subset with a preclinical form of the target disease through early detection and the treatment. So this is where the screening is effective. Then that the disease has onset, but it has not developed signs or symptoms, and then there is a critical point where we have to intercept this disease, the development of the progression, and as well as the cure of the disease. So finally, I'll just give a brief summary about the NSLT, that is National Lung Screening Trial Research Team, that it has shown that there is relative reduction of lung cancer death by 20%, relative reduction of overall mortality by 6.7%, 50% of cancer identified by LDCT, that is low dose CT scan, were in stage 1, and numbers needed to screen to prevent one death was 320. And then there is some cost analysis also. This published in 2011. However, as of now, India doesn't have any lung cancer screening program, but that is the part and that is the topic of today's discussion. So, can IP or the interventional pulmonologist have something in that? Can we do a paradigm shift? Yes. The IP has an edge. We have an ability to detect solid ground-glass nodules. We can minimize the risk of complication, like CT-guided biopsy has risk of 27% of pneumothorax, while the bronchoscopist, when we do it, we have less than 5% risk of pneumothorax. And we can also minimize false negative by now the modalities which confirms the tool in lesion. But you need to have a lot of training in bronchial branch tracing, whether this is manual or software guided. Then there is probably the availability of thin scopes, availability of the infrastructure like RP-bus or cryoprobe. Then CABT, that is C-arm based therapy, or a CBCT, which confirms that we are in the lesion. The procedure happens under general anesthesia, but the anesthetist requires to have a set protocol of the ventilator guideline, and all this we have to manage with the cost when the patients are asymptomatic. This becomes a big of infrastructure investment with almost asymptomatic patients, but with very good outcome. So with that brief note on the epidemiology, risk factors and their implications on the cancer screening, I will end my talk, and I will thank CCI for this wonderful opportunity to provide, and I will now invite our next speaker to join the conversation and to enlighten us on the lung cancer screening. Thank you so much for the patient listening. Thank you so much.
Good evening, everyone. At the outset, I'd like to thank CCI for this opportunity to give this talk at the CME on lung cancer screening. Thank you so much, Dr. Rafi, for the kind words of introduction. And thank you, Dr. Jaykumar, for making my task easier by giving the etiopathogenesis and epidemiology of lung cancer. Without further ado, we will go into the talk. I bring greetings from Apollo Hospitals, Chennai, where I work. For lung cancer screening, the only recommended screening test is low-dose CT scan. It is recommended only for adults who are at high risk for developing the disease because of their smoking history and age. So what do you mean by low-dose CT? It actually has about 1/5 of the radiation of a regular CT scan. So it's making it safer for the routine testing. It has about 1.5 millisieverts of radiation, whereas a standard CT has close to 7 millisieverts of radiation. And the average background radiation a person may be exposed to in a year is 3 to 5 millisievert. The US Preventive Service Task Force recommends the annual lung cancer screening with low-dose CT in people who meet all of the following criteria. Age group more from 50 to 80 years, patients who have a 20-pack smoking history, who are currently smokers or have quit smoking within the last 15 years. And it also recommends that to end the screening for people in this group who develop some health problem that seriously limits their life expectancy, and those who are not willing to have any options like lung surgery if it is required. So why do we need to screen for lung cancer? So we had a very large trial, the National Lung Screening Trial, which randomized more than 50,000 individuals in the US who were at high risk for developing lung cancer. And they found there was a 20% relative reduction in lung cancer specific mortality after 7 years of follow-up. And compared to those patients who had been screened with just a chest X-ray. And other trials, including the Italian trials, the one from Netherlands and from the UK, also confirmed significant reductions in the mortality with the use of low-dose CT for lung cancer screening. The Danish trial also showed a trend towards reduced mortality in patients at high risk of lung cancer is screened using low-dose CT. And the International Early Lung Cancer Action Program reported a 10-year survival rate of 88% in patients with stage 1 lung cancer who had been identified during this screening processes. So what's the Indian perspective on lung cancer screening? Despite having a considerable burden of lung cancer, India does not have a formal lung cancer screening program because we have so many barriers, which include the cost, the logistic constraints, and also the very high false positive rates we are experiencing in our country because of the high burden of TB. So there has been the Asian perspective, which has been stated in the Lung Cancer Screening in Asia, the expert consensus group, which was published last year. And the recommendations were patients who were at high risk for developing lung cancer, including the smoking history and the age must be taken into consideration. And the assessment is based on the standard US guidelines, age from 50 to 75 years, smoking more than 20 years, and years after quitting smoking up to 15 years. These people are still at risk of lung cancer screening, lung cancer development, and they should be screened. So in Asia, what are the recommendations? Non-smokers 50 to 75 years, patients who have a family history of lung cancer, especially in the first degree relatives, and it should be done yearly in high risk individuals and should not exceed more than 2 years. And anyone detected to have an abnormality should be followed between 6 to 12 months with the reference to the lung rats or the Fleischner Society guidelines. And if the age is more than 80 years, we can discontinue the screening. In India, the recently published guidelines on screening for lung cancer was published in JAPI. And this is the reference for that particular article, which is a very interesting read indeed. So in India, a retrospective pilot study had been done in about 350 smokers with a mean smoking history of more than 22 pack years. And they reported the prevalence of lung nodules in at least 93% of the patients and lung cancer diagnosis in 2%. And in another abstract which had been presented at the 17th World Conference on Lung Cancer, it had been observed that screening by low-dose CT could diagnose lung cancer in about 2% of asymptomatic patients at risk for lung cancer. And especially important was these were all clinically stage 1 lung cancers, and the 10-year survival rate is estimated to be about 87% in this subgroup. Really, we have to wait for another outcome of a particular study which is being done now, which is an ongoing trial, a single-arm open-label study in India. where smokers between the age of 55 to 74 years are being followed up. Those who have quit smoking within the last 15 years, patients who had more than 30 pack years, or current or former smokers with 20 pack years, patients with COPD, patients with history of lung cancer and first degree relatives are being screened with low dose CT. We really have to wait for this outcome of this study to see what more information it is going to help us with. So with regard to the lung nodules, which we see in so many of our patients, there are several international guidelines which we are familiar with, most commonly the Flational Society guideline, but we also have guidelines from the British Thoracic Society, the American College, the NCCN, the Canadian Task Force, the Saudi, China, and Asian guidelines, which all recommend low-dose CT for nodule assessment, and it also provides recommendations and algorithms for appropriate follow-up and management of lung nodules. And most of these guidelines recommend that basically based on the patient's age, more than 50 to 55 years, who are heavy smokers, these particular nodules are described as having large size, which are irregular, which are spiculated in upper lobe location, especially in patients with emphysema, pulmonary fibrosis, family history of malignancies, known exposure to inhaled carcinogens. These are all characterized as high-risk groups and need to be followed up. This is a very busy slide, basically depicting the guidelines of the Flational Society, BTS, and ACCP. And when we talk about solitary pulmonary nodule, how do you really screen for it? Depends on the size of the nodule, whether it's less than 6 millimeter, 6 to 8, or more than 8 millimeters. If it is a smaller size nodule, you do an annual low-dose CT. If it is between 6 to 8, the interval following is initially between 6 to 12 months and later at 18 to 24 months. But a larger nodule has to be followed up at 3 months and including doing additional investigations like a PET CT and tissue analysis as indicated. And how do you really follow up from that particular size? This is also given in this particular slide. So which are the patients you really select for the low-dose CT? And why do you really need to do a good selection of the patients? Because there might be a high rate of false positivity due to the higher prevalence of other chest infections or overlapping symptomatology, which can lead to subsequent more and more follow-up images. Patients might undergo some invasive biopsies. They might be exposed to more and more radiation. It's obviously quite expensive because insurance does not cover a free service for all these indications. And the cost of the low-dose CT may also make it difficult to implement lung cancer screening at a mass level in developing countries like India. So you must be very judicious in screening the patients for lung cancer using a low-dose CT. And what is the risk of the low-dose CT? Obviously, it's a radiation exposure. Though the amount of radiation is less, it is always more at a risk and may contribute to the patient developing a malignancy. And the amount of radiation from a low-dose CT is obviously much more than a traditional X-ray. It adds on to the anxiety and stress of a person, especially before the procedure, and the worry they might have about the results which may be subsequently given to them. There might be false positives or other abnormalities. A scan may show a false positive indicating an abnormality that is not malignancy and obviously will lead on to further investigations which will be required. There may be an overdiagnosis. Some low-grade cancers may not pose a significant health threat, but once it's detected, obviously, we have to pursue it further. So what are the challenges that we face about lung cancer screening? The availability of the low-dose CT, the accessibility, the population, all the relative infrastructures which are required to be kept in space. There should be trained human resources to interpret the CT scan, the expenses which are involved, the psychological trauma which the patient might undergo, There's an overdose bias, as I've already mentioned. And it also may detect some indolent malignancies, which may lead to overdiagnosis also. And lung cancer screening programs in never smokers have their own implication, like exposure to radiation, resources being utilized, the cost, and also radiation exposure from lung cancer screening using a low dose CT is obviously more in women than men across all age groups. So what's happening in a few other Asian countries? In Japan, low dose CT is available. It's not been adopted as a recommended screening method for the population-based screening by the government. Still, they use chest X-ray and sputum cytology for lung cancer screening. In countries like Malaysia, they tried a pilot project of lung cancer screening, but it was prematurely terminated because there was a poor enrollment despite having the free access to low-dose CT. There was a lack of public awareness, and smokers didn't really come forward to be screened. So it is also highlighting that patients were reluctant to undergo invasive procedures if nodules were detected. So this actually is a suggested referral pathway of lung cancer screening in India based on the patient's symptomatology, the radiological imaging, and obviously the patient is referred to a pulmonologist. That's more high index of suspicion of malignancy, and adequate investigations are being done. And this is how we proceed with cancer screening. So the take-home message is we need to pursue the entity of lung cancer screening, methods to be implemented, to be followed, and we need to increase the public awareness about lung cancer and lung cancer screening. Thank you.
Thank you, Dr. Jaykumar and Dr. Gayathri, madam. Those two are wonderful talks about the epidemiology and also the screening tools, what you need to be doing and how we need to look forward when we do it. So now I want to open all the four panelists, both the speakers and then the two other panelists who we have, Dr. Dinesh and Dr. Ravi, Dosi, both also to open for the discussion. And then to first to start with, I would like to ask Dr. Gayathri madam itself about the screening tools. She said, what are the, you have elaborately told about the lung screening, but to summarize, what are the indications in lung cancer screening pertaining to Indian perspective, ma'am?
The question of lung cancer screening between the Western world and India seems to be confounded by many things. One is the patient population whom we are seeing. We are seeing a large number of population actually compared to the rest of the world. So that is one main constraint we are seeing in terms of the numbers we have to screen. But more importantly, it is the other diseases which can mimic lung cancer, which we are seeing there, which might be confounding our reports. The disease in question is tuberculosis. So unfortunately, TB is still yet to come under the control of our TB programs and our treatment. So as we all rightly know, when we do imaging for patients who are smokers, who are also at risk for other infections like TB, sometimes we are at a crossroads. Are we dealing with a malignancy or are we dealing with an infection like TB? So this kind of a burden is really something which we really have to cross, and it's a hurdle for us to cross compared to the Western world where the TB incidence might be less. The other thing is the cost constraints also. Doing a CT imaging for a person who's going to spend out of his pocket, we tell him he's at a high risk, his age is more than 50 years, and he's a heavy smoker. Asking someone to do a yearly CT scan is obviously going to be a burden on him. especially if we're going to tell him that it has to be done almost annually till we find out whether any changes are there for him. And we have to wait for quite a number of years before we can really stop all the screening process. So these are some of the important challenges which we face in our country. But going forward, we can't really ignore the immense burden of lung malignancy we have in our country. So we have to do something by creating more awareness for patients, at least the smoking part of it, to stop smoking, to encourage a healthier lifestyle, to cut down on air pollution and all those carcinogenic agents being released into the air. So all those things also need equal focus in addition to the screening and the awareness.
Okay, that's. I think you brought up an interesting point, ma'am, because with the large volume as we are dealing, to be having other confounding factors have to be dealt with in a large populous area. So I want to bring back to the question a little bit. See, when you see how, Jay Mehta, this question is for you. How global and regional trends in lung cancer incidence and mortality has changed over a period of time? And then how do you see in the, when compared to global to the Indian trend?
So I think this is a very fundamental and a basic question, Ravi sir, that over the period of time, as I have depicted in my talk, the lung cancer was once considered an rarity and oddity. That was before around 1930s and 1920s. But then, as we see now, the lung cancer tops, and it is one of the most common cause of cancer-related deaths. Now, why this paradigm shift has happened? Why this incidence and prevalence and mortality has risen so much? It's because of only one thing, that is tobacco smoking and rise of industrialization and tobacco industry. So this is a very important thing, that there is clear-cut environmental exposure, clear-cut cause and effect relationship of tobacco consumption and smoking with that. Now, if we see what other governments are doing, this is very important when it comes to the Southeast Asia, particularly our country. World is having 8.8 billion population right now. Out of them, 1.1 billion are active smokers. Among them, 940 million are men, rest are female. So this is large burden of active smokers. Now, the one thing which they have in their mind, that all smokers doesn't develop lung cancers, but at least 10 to 20% do develop. And when it comes, because of there is large number of people who are smoking, it comes to a very large number of people getting lung cancer. And it has to be come under control with the help of strict laws and regulatory requirement, which the Western world is doing and we are not doing. Like, I'm sure even in Ahmedabad, like the city of Ahmedabad, there are certain areas named under tobacco giants. In India, there is big company. I'm not going to take name of that, but this big company who is also listed on stock market, and they're actively promoting smoking. And these are things which is actually not happening, which is not, there are no legislative measures to correct that. Yes, they can increase the taxation, they can make them more costly, but still, I would like to enlighten this fact. I was reading a book on how this actual images, which they are stating the warning on the cigarette and tobacco packs, basically it increases the craving. The functional MRI studies have shown that it is a pathetic marketing, and it actually increases the craving in these people. So we have to brought the tobacco consumption down, and that is one thing which is happening. That's why the incidence, prevalence, and mortality are more in the Asian countries, particularly Southeast Asian countries, and this is where it is rising. Again, coming to the industrialization and exposure to the harmful dust, chemicals, and poisonous gases, PPEs or personal protective equipments are not used. The stringent measures are not being used at the to cultivate down the occupational hazard. So I think it is finally the mix of tobacco industry and the industrial exposure with less of education about the PPEs, which is culminating to the rise in global as well as particular Southeast Asian region, the trends of lung cancer. And I think that is the answer.
Okay, that is a very elaborate one. But I want to bring on the same topic technically about how the regional trends when is happening, as you, Dr. Jay, has brought in. This question is to Dr. Dinesh. Dr. Dinesh, before answering the question, because we didn't have displayed a slide of yourself. Kindly introduce yourself and then answer this question. But I just wanted to ask, and then I'll come back to Jay to wrap up this question. What are the environmental and lifestyle risk factors associated with lung cancer you think is impacting, Dr. Dinesh?
I am Dr. Dinesh, professor and head at St. Philomena's. Previously, I was working in a cancer hospital myself, and I've undergone training in pulmonary cancer situations. Now, coming to the risk factors, in Indian scenario, there are plenty. Like when I was doing my MBBS back in those days, they were telling, it was almost 10 cigarettes per day. This is back in 1990. So now you can imagine how many, because of the pollution, you can just imagine how many cigarettes per day we are smoking. And I live in Bangalore, and the Bangalore traffic it's really horrible. As Dr. Jay had already pointed out, we require a strong legislation, not only to curtail the tobacco products, but also to get in good environmental and safety procedures in a working environment of a company which deals with a lot of industries. Of course, in my state itself, there are a lot of mining going on. In fact, my father used to run a small scale industries where we used to pack the paper plates, a paper thing, and all. I mean, I gave up that, and we also used to run a transport company. So we need to resolve and get our own resolutions by ourselves, and not only depend on the government. But unfortunately, there's not much that we ourselves are doing. Like Praja, like the leader. But unfortunately, that is the truth. Yes, we need to look into a lot of aspects, training the patients, or getting the good clinical history, and also looking into all these environmental products. And I think that should do. I think Dr. Jay has mentioned a lot on that. And let us not get into the controversies, but that's a fact.
Okay. Yeah, even as you said, in the metro, even I am from a metro, like where Hyderabad also has boasted, like as Jay has mentioned, Ahmedabad has a tobacco high scale producing top-notch companies are also there. But Hyderabad also has historically locally producing, they call it, I think, I don't want to take the name as well, but like we have very popular, Charminar and other different name brands are there. Locally producing is also there, but I think that is also as parallelly driving the industry where it is increasing the consumption also is more what we see.
Yeah, see,
the regulation locally has been curtailed, which is not very impactful.
See, when they produce the cigarette, there is the leftover of the tobacco, which is again resold, and that is used in the BDs and in the other products.
Okay.
And much more than that. So until unless we come with a strong legislation, I don't think so. And also, I know in public places we have the smoking areas and non-smoking areas. I don't think so that is also helping. So there are a lot of these things which we'll have to look into ourselves before asking the government to do something. But unfortunately, none of us are doing anything much. Okay.
You want to just add, Jay, anything on that lifestyle risk factors associated with the lung cancer?
I think, sir, it's summing up that with somewhat dimension on the clinical history domain. This question was designed so that when the patient comes to us, when we ask that, are you a smoker? 99% you will get the answer, no, I'm not. Then we have to reframe the question that when did you smoke last? And then 10% will tell that I smoked around 4 days back, 4 weeks back, 4 years back. So this is the clinical questioning which I want to send to our all GIST community, that we have to frame our questions correct. And we need to determine the smoke exposure in the back years. because that has a lot to do when it comes to the lung screening part. Third, most common is, as we have depicted in our talks, that this starts from the age of 50 or 60s, probably. The lung cancer develops in 50s, 60s, and 70s. So when we are talking about even the occupational exposure, there is a phenomenon called a lake phase. So when you are employed in certain industry, you don't get lung cancers like that. It takes some time, and unanimously it is around 20 to 30 years. So when you ask and take the professional history or occupational history, you have to track all the exposures because most of them will be retired, or either they are doing office work. But once upon a time, they may be exposed to around 10 years or 15 years of this type of occupational exposures. And hence, for lung cancer screening, it is very important that you have to go into detail that from where you started. These are some clinical pearls which we usually adopt in our lung cancer screening part, and I think that will help to the patients also.
That is a very good summarization.
Yes, I think basically we'll have to be more persuasive and be more creative in asking the questions so that we get appropriate answers. Yes, Dr. Jay. And Dr. Krishna has just messaged saying that we have 1,242 logins today.
I think quite a number of smokers in the country. So the logins are also high. Anyway, I'll bring it to the so Dr. Jayaraman has been from Tamil Nadu, has been mentioning a fantastic presentation by Dr. Jay and Gayathri ma'am. So he's congratulating on that as well. Okay, so Dr. Ravi, Doshi ji, I am bringing back a basic question. So all this discussion happened and all, but a bit, what do you think about this LDCT and then Indian scenario? The low dose CT and then Indian scenario.
Thank you, sir. I'm Dr. Ravi Dosi. I'm a chest physician from Kokilaben Hospital, Indore. Well, sir, LDCT, when in a single breath you do the CT scan, it definitely is a low radiation exposure technique. It gives significant advantage in terms of lead time bias and length time bias. These lead time bias means when you can diagnose the cancer earlier than what it would have actually presented with, and length time bias means you're actually cutting down on the doubling time. So both these techniques give a very big boost to LDCT being propagated more and more, because if you're able to diagnose more early, you are definitely catching them in stages which are surgically curable or medically curable. So LDCT prospectively is a very good technique. But as we come down to ground reality and we look at our own practice and we look at day in, day out affairs, we see that although this LDCT is proposed to have several theoretical advantages, but even the biggest trial which has been done, the National Lung Cancer Trial, it does not offer any mortality benefit. That is one fact of the matter. And that is the reason why no government is ready to take it up wholly. So LDCT is excellent, but sadly, because of lack of the proper mortality benefit arm, I feel that it is not able to achieve a public dimension. That is my take on it, sir.
Fantastic. Ma'am, Dr. Gayathri, ma'am, the question is to you on the same thing. What is in your perspective, what do you think are the pitfalls in this LDCT?
The pitfalls for LDCT is one, I think it starts with the patient selection itself. As we talked about, when patients come to us with some complaints and we find some kind of a radiological abnormality, and we come to also ask them once again, are you a smoker? That question itself is half the time not answered correctly or truthfully to us. So it's even in however manner we frame the question. So I think with each patient, our experience grows enormously. So we learn from the patients on how to ask questions further. Like we ask them, have you smoked before? No. When did you last smoke? It could have been just 1 hour before coming into a room also. That's also been told to me. So that is one thing. The other thing which I find is they come with their family members. Sometimes the family members don't know that the patient is a smoker. They don't know that the patient is continuing to smoke. So he has claimed that he has stopped smoking. So they don't want to accept that. The other thing, unfortunately, which I've seen as a new trend, or maybe it has been there in all other cities also, They might have been covered by some insurance company for some various other schemes and all those things. If they declare themselves with either some history of smoking or alcohol intake, whatever medical benefits are given to them by their company person or their insurance company or whatever claim benefit goes away abruptly. So they never give that history at all. So that itself becomes, do we really have to recommend a CT to someone? So that becomes one question. And I agree with Dr. Doshi's comment. The largest trial did not show the mortality benefit. It showed that it had been picked up. The tumor had been picked up. But did they survive out of it? No. It really depends on how soon it was picked up, what kind of therapy was offered, what kind of stage it was. If it was stage 1, obviously it's going to be operable. But if it's going to be confounded with other disease ailments and all that, it becomes something which we can't treat. And what is the accessibility for our patients? I do not find many centers even advertising for a low dose CT. Obviously, the cost is going to be a constraint for them to do it widely and publicize it widely. As doctors, we talk about the amount of radiation is going to be less. The patient can have it done annually. So on paper, and we can talk about all those things, but practical reality, we have to see that. Is it other scan centers in other places going to do such a low dose CT at a lesser cost and cut down on their profit margin when they are actually coming to a reality when we ask the patient to do it? If they're going to do it at this place where we work in the hospital, we know the protocols are in place. But is that going to happen really? The other thing is, is this patient going to come back to us for a follow-up? This patient is a regular patient to us and they're going to be faithful to us and be our come under our follow-up regularly. Okay, we can follow them up. We can measure the nodule size. We can see and do all those things. But a new trend has come. I've seen doctor shopping. Doctor shopping, hospital to hospital, city to city, within the hospital. Usually it used to be, I would have seen some years ago, it will be morning, they'll see one consultant. The afternoon, they see the other one. Now it has been more advanced. Morning itself, they see 2 people. So it's, are you the number first choice or second choice? It's not even the choice. Did he get an appointment to do before he got it with the other person? So that's how it's going. And I was a little bit curious to find out what was the reason for this amount of doctor shopping. The patient's thing is, he has come from such a long distance and he is concerned about his ailment. So he decided to take this new kind of second opinion. So the opinion also varies. The advice also may vary. So a lot of bias is happening from the patient end also. They might have been told they have something abnormal with them, but how much are they going to accept it? How much they're going to take our advice forward? That itself becomes questionable. So that's where it's coming in. Though obviously we have to screen for the disease. There's so many things for us to hurdles to cross before it's going to be a reality that we're going to do an early pickup of a lung malignancy and treat it at stage 1.
Okay. So, I mean, as you said, like so many layers involved in this LDCT, where you actually convince the patient and able to do and then get to a point where you can diagnose and pick it up. So coming to, as you asked rightly, the questions, clinically, as a clinician, we asked about, are you a smoker? When is your last smoke? So there is a saying, I think I just wanted to put it on a lighter point, is like each break between the cigarette is a cessation. So it's pretty much like it for a person. So on that same note, I want to ask Dr. Jay about the impact of cessation, smoking cessation on lung cancer, risk reduction. What is your take on that? And more on Indian perspective.
So, sir, this is again a very important question, because many of the time when we suspect a patient with having malignancy, and we get the answer that they have stopped smoking, they'll ask this very important question that, sir, I have stopped smoking. Why did I get this? So there are certain statistics that the patients who are regular smokers, they are definitely very high risk of getting lung cancer than the persons who are never smoker. So never smokers are defined as having exposure of less than 100 cigarettes in a lifetime. While the regular smokers, they are already having regular at least 1-2 cigarettes or 1-2 packs per day. And then we need to quantify how much they are smoking. So the persons who are regularly smoking at least one pack. Now, one pack, other part of the world is around 20 cigarettes in a pack. Somewhere around, some brands are 10 cigarettes in a pack. And then there are concept of BDs. So there are 20 BDs in a pack and 25 BDs in a pack. So it is a bit ambiguous and arbitrary for us, but then we have to quantify this exposure of smoking. So the persons who are regularly smoking around 10 to 20 or who are 10 to 20 pack a smoker, and when they go beyond, they have enormously high risk of development of lung cancer than those who are never smokers. Around, as I mentioned in the slide, around 60 times more. And then the persons who quit smoking, then again, it is very important, when did they quit the smoke? So in the lung cancer screening, they have specifically mentioned quit smoking in last 15 years. If the person have stopped smoking in less than 5 years, they are still at the higher risk. So the good time to smoke is to quit smoking is as early as possible, maybe before age of 30, 35. It's been told that once you have stopped smoking at the age of 30, 35 years, the risk of getting lung cancer is almost coming near to the never smoker, but it never gets eliminated. The more later you quit smoking, the risk still decreases than those persons who are active smoker, but it's still double than of a never smoker. So then it has to be conveyed that you have quit smoking since last 5 years. It doesn't mean you eliminated completely the risk of getting lung cancer. So the 15 years, I think the 15 years, it's a very important mark that if you have quit smoking before 15 years, then it means that your risk is less, but still it is high than never smoker. But if you have quit smoke less than 15 years, then it is still tremendous and it is still higher on the higher side. So it is very important for as a community to deliver this message to and address this, that what is the risk of getting lung cancer even if I have stopped smoking it regularly. So I think I got it cleared with this answer.
Fantastic. So yeah, this is a burning question as usual when we are thinking about it. And also I wanted to bring in Dr. Dinesh. Dr. Gayathri ma'am been mentioning about the pitfalls of LDCT, but on the same token, in the screening mechanism also, what are the difficulties we are facing in India? I think in indirectly or directly, some points have been mentioned. So what do you see in the Indian scenario? Because you're also coming back from a cancer hospital work and then leading in a center earlier. What are the difficulties that are being faced in the lung cancer screening in India?
Two major things. One is acceptance.
Okay.
And one is monitoring.
Okay.
And it is very difficult to make patients, like Madam was saying, the doctor shopping. So they come and see you, and then you ask them, once they come with an X-ray, and if you find a nodule in there or some abnormality, and if you would wish to or you would want to, and if it is necessary to do a CT scan, they would say, okay, we will get it done, but why? And then after another 5 minutes or 10 minutes, there's another patient attender who's coming in and asking, why should we do this? And this is just about the CT. And after the CT, if you ask them to go for any interventional, biopsies or whatever, there's another big question. And you get another 100 calls from so many different doctors, even within or outside the city. So this is the major thing. Secondly is a monitor. So there is there's a saying that, they will go to a restaurant, a 5-star or 7-star, they'll be prepared to pay for the same cup of coffee, which could cost you only about 10, 20 bucks. There they'll be even charging you around more than $1,000. So they are prepared to pay for that rather than paying for their own thing there, So we are at the ends where we will have to really, get in a lot of thought process to make them understand and accept it. Thirdly, again, there would be these Google doctors.
Yeah.
So they go in there and they say, there's this much of radiation and this much, and then we'll have to tell them, this is the calculation, this is the radiation you will get in, this is the radiation you're exposed to, that makes it a little bit more difficult. So I would suggest, get in, and of course, not the least to say our own community, they say, okay, no, this is not necessary, we can wait, when they go do the doctor shopping. And they say, no, we can wait. I mean, of course, they might not be the pulmonologist. And as you know, there could be many other departments saying that, no, we could wait, we could do this. So that is another hindrance. So once you get them to understand and do that, it is very, very difficult. And last but not the least, once you say a X-ray or a CT scan, none of the the insurance companies cover up. None of them. They all outrightly reject. They say, no, this is not necessary. This is only necessary for individuals who are that. Because these guys, as the panelists told, that they wouldn't have declared that they are the smokers or they are working in so-and-so company or so. So it becomes difficult for them to claim it, if at all they, tell that. So that is another hindrance. The major hindrance are these. But of course, there are a lot of others. But these are the major hindrance which I face, or which I faced, have been facing all these years. Acceptance, monitoring.
Acceptance and monitoring. I think a good words there. So I just want to bring in again Dr. Ravi Doshi ji. See, the emphasis on the clinician, like with this many difficulties, emphasis on how you want to bring in the referral of a pulmonologist, and then regarding the evaluation part with the lung nodule. So what is your perspective?
Well, sir, my perspective is that first of all, in most clinical settings, whenever you find these sub-centimetric or these nodules which are scattered, most are considered benign by the EHC physician. Then very rarely, if the patient is having a high risk situation, like he might be a smoker or there might be a family history, then only they are referred to us very commonly. In that situation also, if you can see, nowadays it is very common to be interventional or non-interventional. Many of us, our colleagues, will be advising, chalo, let's see, in 6 months we'll do a follow-up scan in 1 year. But the interventional guys will go on to do a radial EBUS and try to pinpoint the diagnosis. So again, if you see in the pulmonology community also, first of all, I would say hardly, like Gayathri madam told, we will be receiving 25% of all patients who are actually having nodules. Of that, amongst us ourselves, there will be very selected few who will be going ahead for further evaluation. Most will be asking for a repeat screening after 6 months or 1 year. I think this is the practical scenario which I am seeing.
Okay. Madam, Dr. Gayathri, what is your take on it regarding this referral to the pulmonologist and then lung nodule evaluation? You have actually dealt in detail comprehensively in the slides, but I wanted just as a summarization.
Basically, sir, it really depends on which specialty doctor is seeing the person with the lung nodule. Obviously, the perspective of a pulmonologist is going to be more different and more precise with the approach than a general medicine person or a person with general medicine background. That's what I've seen. Because the same patient, they would have seen a physician, they would have seen a lung nodule. But the reason why the patient came to see you is because patient Googled that report. And Google mentioned something malignancy. So with that thought in mind, some of the patients come in. Some of the referrals, obviously, your colleagues, they know that such a kind of a nodule or whatever kind of size or something looks alarming, they might refer to you as a pulmonology consultant. But sometimes it's the self-referral from the patient, and Dr. Google, though has been a hindrance, sometimes it gives us some referral patients also. So we get some patients like that. So only then, I think from the pulmonologist perspective only, we can even go and categorize what kind of size the nodule is, what is the risk factor, when we do have to do the imaging. That kind of pathway we can drop for the patient and do it. And as Dr. Doshi mentioned now, we have additional investigations which we can offer to the patients. Earlier on, we only had imaging, we had bronchoscopy, then we had CT guided biopsy, PET for lesions. Okay, we do a CT guided biopsy. PET CT also is limited by the size of the nodule. If it is between 8 to 110 millimeters, it becomes a kind of an indeterminate kind of an size. If it is more than 10 millimeters, okay, then we can get a report which will be conclusive to tell us, even if the PET is it's a non-FDG await nodule, we can ignore it. But if it is that 8 to 10 millimeters, still it is something. We ask the patient to do such an expensive and invasive investigation. So invasive in the sense we are giving them this FDG injection. So it's compared to giving a contrast, we are giving an additional injection for the patient, subjecting them to radiation and then telling them, okay, still I don't know what's happening. You have to repeat this investigation after about 6 months. That is the correct time the patient will decide in his mind, let us change the doctor. So that's what I've seen. We have to be more cautious with our reputation and also keep the patient with us for both things, to offer our services as a medical professional and also to allow us to continue doing our profession also. So the other newer modalities now we have been made aware in our CCI group itself. We have been made aware that the certain centers have started lung nodule clinic. There are a lot of centers all over the country have started the EBUS services with the convex probe, radial probe, EBUS, and how to access a distal nodule under guidance, under navigation bronchoscope. So the scheme of interventional pulmonology has also increased in what we can offer to the patient. At the same time, we also should balance between, do we really do all those investigations or do we wait and watch? And we should be also, I would say, prudent in choosing our patients. Which patient we should offer all these detailed investigations also. Because we also need a positive result for us to go forward and tell that we have done this procedure. It has also given us an aid to help the patient and come to a diagnosis. It is not merely the number of procedures we do to hype up our numbers is important. We should also prove that we have done so many patients and this caused so much of outcome difference in our patient care. So that's where I will say we have to balance both. The investigation which we offer, when to do it, and also when not to do it also.
Fantastic points, madam. Actually, because the changing age, not just the guidelines which you have been offered, where you follow a certain protocol and then be able to fall back on them and then see whether it is evolving or not. But I think you need to amalgamate on the same tone as rapidly evolving interventional things where you can appropriately when you can actually use it. So, but not overkill it. So that is also a point where we need to observe. Now, I want to change focus again with a question to Dr. Jay. What about this occupational exposure such as asbestos or radon contribute to the lung cancer risk? You mentioned in a couple of slides where it looked scary. And are there particular populations that are more vulnerable and then how to tackle with it and how it is when compared to the industrialized nations to our nation or, our segment of population?
So, sir, mainly this again goes back to the taking professional history of a real good 25-30 years of history of a patient, that to how much hours of work you are doing and how much work where you are exposed and whether you are using personal protective equipments or not. When it comes to the industrial standards in our Indian context, most of these people are not that skilled workforce. Particularly, they are not aware of how to take care of themselves. On top of that, they live in pretty petty situation where there is not good ventilation at home also. Plus the burden of tuberculosis and frequent respiratory tract infections. Like in Ahmedabad, there is entire area which is dedicated to this industrial zone, where the air quality index is very poor from rest of the Ahmedabad. So these are the people who belong to the low socioeconomic status. They have very ill ventilated home. They have patients with the respiratory tract infections as well as tuberculosis in their household, and these people are very high, very high risk. The subset of very high risk, where they will get this lung cancers in future. Plus, they are also exposed to regular form of tobacco smoke. Also, they have Jula smoking and environmental tobacco smoke exposure. So, not only from the professional, from their own recreational pursuits, not from, but they have multi-pronged exposure to this type of hazardous chemicals, toxins, and fumes, plus the air quality which they are breathing in, and which makes them very much vulnerable and at risk of development of lung cancer in a future date. Let's say after around 15-20 years of living in the same household, they will be developing this. So it is very important. Now, there was, from my end, I was trying a lot to not only get the lung cancers, but also the airway diseases, because these people are at high risk of development of airway disease, obstructive airway diseases too. Now, the very shocking fact which I got from all this, that once you diagnose this environmental type of hazards, then it becomes under the laws of compensatory phenomena. So if the employer has to bear the cost of it, and sadly because of that, in industrial hygiene, industrial standards, they don't get pulmonary function tests even done. Let the lung cancer screening part aside. So this is one thing which is roadblock for me approaching the industrial zones. That how do we bring, these are all poor people, at least we go there, write certain medications, write certain inhaler treatment, but this is making something very shady in that part. So these are the particular vulnerable subset which requires higher training, regular PFTs, regular lung cancer screening, particularly after certain age group of around 50, 55, where we can get exposed to the, where we can get early detection. So we have to look for the people who are employed in the construction work, particularly roof business, where the asbestos exposure is high, the mining work, as well as cotton and textile industries. Mm-hmm. So these are the areas, particularly when you are getting, particularly welding. Welding is again a profession which is associated with high risk of lung cancer. So we have to go very much into the detail. Automobile industry, transport, some people are transporters who are regularly exposed to the exhaust and fumes, where they are exposed to the PAH. So this all can make them very much vulnerable to development of the lung cancer, and that we need to focus really get into the detail questionnaire, as well as to lower our threshold for the lung screening in that person.
Yeah, fantastic. I mean, like to hear to it, the things which we are inheriting with the superseding industrialization and then modernization, right there. I want to ask Dr. Dinesh chip in opinion on this. Dr. Dinesh.
Yeah, I think Dr. Jaykumar has summarized his thing very well. See, history taking is one. And, even when you ask them if they are farmers, they come and tell you they are farmers. You'll have to be appropriate in asking them, what sort of farming they do. For example, in the part which I live in, about 100 kilometers from here, they grow a lot of, the grapes, pesticides. All these things, it makes, there are so many people who have gone into Parkinsonism also because of these pesticides. So, we need to ask them what sort of farming. So history basics, once we start having our basics right, I think we should be able to zero down on them, especially the history, where do they work? What is it? Sometimes they only tell, we just work there in a factory there. But what sort of a factory? Including, they come and say, no, we are just the operation managers. But what sort of an operation manager are you, for which group of people, for which company? So these are the things which we'll have to keep asking. So it's very important and prudent there. Secondly, again, I had starting, when I come down from the US to my country back here, I had starting these PFTs, in certain companies, just to identify, give them a special hand so that they could identify a few people with respiratory diseases. And I'd also extended this into the farming industry locally, just to give them, the push through to because the PHCs were struggling to get in these people to get their things. So I just offered to do these things. So I did find a lot of restrictive lung diseases there. Those days, even when to get the X-ray done, it was difficult. Though the PHCs there did have some amount of equipment, getting a few investigations, convincing them, though it was free. And to know, even now, today, the government actually gives some amount of recommendations and, monetary benefits to certain industries and all that stuff. But unfortunately, it is not looked upon or not really, whatever say. So, those are the things. Yeah, I think Dr. Jay has put it wonderfully well. Yeah, we'll have to look at the history, and cautiously we will tread on them. And I think that is what it is.
Okay, fantastic. So, though, bring back, because looking at that, bringing back Dr. Ravi, I just wanted to ask, because you are, I'm starting this question with you because you are big on public awareness when you do with your little videos and then what we see on the CCI. So I think, what do you think about regarding lung cancer screening, and then what public awareness is important, and how do you think is in India will be a useful tool?
It's a very important aspect, sir. And now, as the generations are getting more aware towards the role of screening, we need to create awareness that people go in for this investigation. Let it not be covered with insurance or anything, but still, I think we are capable. We have CT scan coming in very all costs nowadays. So LDCT is not such a big deal. I think if we create proper awareness, then definitely lung cancer screening can prove as a boon. Like Dr. Jay told, that India is now on the topmost charts of all lung cancer incidences. So we should promote this, and I think with awareness, this cost factor can be tackled. And if you ultimately see that there is a cost benefit in this lung awareness program, lung screening program, and if we are able to catch even one patient, then that can change not only his but even his family's fortunes.
Fantastic.
Sir, I would like
Gayathri, ma'am.
Sir, I would like to add one thing, sir.
Want you to.
Sir, I would like to add one more thing, sir.
Please.
If you allow, sir. Only 2 minutes.
Please. Yeah.
Sir, this is regarding a personal sort of experiment. This is very vital question. How can we raise awareness for lung cancer screening? So before around 7-8 years, I was part of a tertiary care institute, a corporate hospital here. And then there was an thoracic oncosurgeon who joined our institute. So we made to make a big impact that now we are offering the services. So we had a good roundtable meeting, some 8-10 people that who are going to participate. And then the marketing people give us insight that lung cancer screening camp will not be a good word, because this happens. People don't think that I'm getting cancer, even the persons who are actively smoking. So then we dropped the word cancer from that, and then we put lung screening camp with the intent of getting cancer screened. That was a hit. Around 474 people attended our OPD. It was a free camp at a tertiary care hospital. It's a big hospital. Unfortunately, I ended up seeing around 200 patients that day. We only got 10 people because we had a questionnaire. There was a team of medical officers, and the three screening criteria, either the age criteria, the smoking criteria, and quit criteria. And then they have to pick, and then we refer to the screening. Only 10 people came for screening, and only 2 people came up for the follow-up. But rest all, it was so hit camp that I got non-lung cancer patients so much in my OPD now. So this is one experiment, a real life experiment, that what we did was this, and ultimately it didn't intend it into the outcome what we wanted. But still, we found a lot of respiratory diseases in that. So that was a small input. That's what we did as a real time, what the corporates think, and this is what the outcome was.
Fantastic. Usually even happens with a lot of people, like you wanted a cardiac checkup and then they wanted to check for the angio. Elderly, I see, like parents and all, they are not ready for angio or for any investigation where you want to pick up really a disease. They don't want to go through it. Let's live with it and then we'll move on. So I think when you're screening, I think in a disguising manner, looks like a fantastic idea to actually get involved all the people. Ma'am, I think I want to bring back, as Dr. Ravi is also mentioning about it. So what is your take on how to emphasize on a public awareness and, as a summation from your side regarding lung cancer screening?
I think in terms of lung cancer screening, we have to really emphasize on the main harmful effects of smoking first. Okay. So only once we emphasize on that, will I think patients have some awareness that they're doing something wrong, or their people around them are doing something wrong, and they might be at risk of some catastrophic illness, and they will at least seek attention for their medical ailments, or at least if the doctor is counseling them to do a CT scan counseling them to do other investigations. Once they found out some abnormality, they will accept it. So I think that's where we actually should aim at the public awareness. The harmful effects of smoking and on smoking cessation, that has to be emphasized. And it has to be emphasized. I think earlier on, I used to think we have to emphasize for the patients. Then I thought we have to emphasize for the college going people, students. But now I think from the school age itself, because now I find most of the younger population who come in for OP consultations with COPD changes on their PFT, they have all been smoking from their school age. It has to be emphasized, start young and emphasize on that. That should be the start of the public awareness against the harmful effects of smoking. And then there will be more awareness of lung cancer, not only lung cancer, all kinds of malignancies are induced by the smoking. So it's an overall, for the overall well-being of the patient. So that has to be highlighted. And also, it also has to be emphasized that the screening program is not a one-time screening program. If the patient is at risk, it has to be done annually. So all those things also have to be emphasized for the patient. That's the regular follow-up has to be done, and they should continue the follow-up, preferably with the same doctor and at the same medical center where they are doing the follow-up.
Okay, fantastic. So, like as we summarizing most of the questions regarding this burning topic, I just wanted to bring in one question where there is a bridge. Like we are all pulmonologists who are actually speaking about it, and then we seeing the perspective. So there is one question which comes in role, like when oncologists getting involved, they want more. Once you give hand over to them as a diagnosis, they want more information. So they're going into the more, looking for the genetic factors and what are all other things. Like Dr. Jayaraman is also just asking about what is the role of a liquid biopsy in the lung cancer screening as well. So yeah, so your take on that, ma'am.
It is a very interesting question Dr. Jayaraman has raised about liquid biopsy. Basically, it is like you're trying to look at the small circulating tumor fragments, circulating free tumor cells, and you find out what kind of mutations are possible. But is it really sensitive and specific to come and identify a malignancy, which we need to do so? That is one thing that we have to answer. And obviously, it can't really subtype the kind of malignancy or the staging. That is not possible in this particular investigation. And the other thing which I see in referring such patients for some investigations as and when required is not very freely available also. It's only done in certain specialized centers. We have to outsource it to those centers. It is also equally expensive. And it might be more cost effective to do a low dose CT than to get this liquid biopsy also arranged. And the time frame to get the results also, because on an average, I think it took about 25 to 30 days for the report to come back. So it's like 25 to 30 days of endless emotional trauma to the patient for a screening procedure. So this is something which we have to technically be held responsible and be answerable to the patient. So you know how it is. Patient goes to the CT scan room, they come out of the room, they expect the doctor should have the result on their table. So if you tell them it's going to take 25 days for the screening procedure to come, I think all hell will break loose at that time.
Okay. So Dr. Jay, what's your take on this? Genetic factors playing lung cancer risk.
So, sir, with a brief note, I recently got a patient, Jayaraman sir. This is answer to our question, only 1 minute. So the patient profile was 70 years old gentleman, never smoker, who got left-sided upper lobe carcinoma. We diagnosed adenocarcinoma from the EBUS TBNA. That's way back 2 years back. Post chemo, radiation therapy, and now on IO. He is on crizotinib. And now in June 2024, there was PET scan which showed right upper lobe development, but there was it was a groundless nodule opacity, but no PET uptake. Just recently, it showed some activity. SUV max increased from 2.8 to 5.2, and from that I did EBUS TBNA, and we found that this is malignant. In that case, as the patient is post CT, RT, IO to select what regimen to get, medical oncologists had decided to go for liquid biopsy. So I think probably the role real time is there. Even he didn't went. The patient is with the medical oncologist since last 2 years, and now I'm involved back because there is another. Surprisingly, left-sided malignancy is gone. Subcarinal lymph node is PET negative, but now only there is the tumor is only in the right upper lobe. So from that now he is getting a liquid biopsy detected. So summarizing, sir, this is where the genetic predisposition comes. This patient is never smoker. We have around 38 trillion cells in our body. It is very difficult to explain how this turnover. I usually tell my patients that to see your childhood photos or the photos before 10 years. Now it is you in your photos, but now you are a completely different self. So your cells constantly change, and there is a process of cell turnover. And with that turnover, that happens some mutational changes, because every time it's not the same copy of the cell being made. And then there are mutations like EGFR mutations, there are ALK mutations, and some mutation you get developed at certain age. And because of this aging factor, your chances of getting development of the lung cancers or any sort of cancers rises. And that is how I sum up that even if you are not smoking, there is some genetic predisposition. We don't know. Even if you are not involved in this occupational activities, even if you are office worker, so let's say some obesity is also considered a risk factor. OSA, sleep apnea also has a linkage with the development of the cancer. And this all sort of play a role with your genetic predisposition, your lifestyle modifications, your lifestyle factor play a role in that. And that is pretty well I sum up the case, that this is how you can get a lung cancer even if you are not exposed to the risk factors.
True. I mean, like even oncologists getting here and saying that, just for an example, APP1 mutation is usually seen in the non-smoker women in adenocarcinoma. So something has been mentioned so that is also helps indirectly about the screening early, looking at in the family there is a cancer, and in the same as a follow-up. So I think that was a fantastic discussion by the fantastic to start with, fantastic oration by both the speakers, and then the wonderful participation by both the panelists. What I see, we are closing in about a couple of minutes. What I feel. Any last words from Dr. Dinesh?
I would say, if you're closing in, I would just summarize it like this. If at all we are looking at the screening perspective, we'll have to get the team first. In my team, I've always included a psychologist and the radiologist. And when I do a biopsy, I always include the pathologist as well. But I always make sure that I look at the slides, I look at the CT scans, I personally look at the data of what is it, and then only proceed. So I would say it is a multidisciplinary team approach, including a psychologist. It's just not for the patient per se. It is also for the family members. They are also, in fact, if I can take a liberty of a few more seconds, a few more minutes, I had a liberty of treating one of the liquor barons. I will not mention the name. So he did come up. He did have, like what Dr. Jay was saying, he also had these splitting tumors. So when he came, the second one was a little difficult to make him understand. In fact, the first one, he was very brave. He came out and all that. But the second one, he was literally, saying that, no, why is it happening to me? At the same time, I had a MLA. You also had the same fleeting tumors. So they both had a talk and saying that, no, we should not go ahead and do all this nonsense. But then we had to literally talk to them. So the psychologists, psychiatrists or psychologists, they play a huge role in actually, trying to get them to the perspective. Secondly, then there is when I was involved in this indoor and outdoor pollution screening by the ICMR, this was back in the 1990s. So like that, we should also have the social welfare workers where they could go to the district level or even the thing, then, screen these patients. It's just not the smokers, even the non-smokers can also be screened, so the factory workers and all that. I think we should approach it in that way. Last but not the least, we should always back each other up and not say that, this is not right, that is not right. The X-ray is not showing that. For X-ray, if you just take an X-ray, sometimes we can miss that. There are blind spots in the X-rays. So the low-dose CT scan is a thing there, but of course, post that, how do we diagnose? Nowadays, we can even do a biopsy in 4 mm. We have a lot of BTPNAs and all that stuff. Radiolibus. There are so many things. Thoracoscopes. Even for the thymus tumors, we do a lot of the thoracoscopic approach rather than the this approach. Cut and paste. So these are the things which we'll have to look at as team approach. Socially, and it will help in economically as well, and get to know and back each other up. That's my take. Yeah.
Okay, fantastic. So Ravi ji, quickly.
No, I just feel that more awareness is needed regarding risk factors, and those who are having family history or risk factors, they should try to undergo this program. Forget insurance, forget any other support. It is for your own good. If you get a good lead and you pick it up early, you can end up saving your life and adding more productive years. So I think lung screening programs need to be given a more thrust in a positive way.
Jay?
Sir, I completely second over all panelists and speakers, and we must have a lung cancer screening program at an institutional level, at the local level, so that we can benefit and benefit the patient and treat them as early as possible, and increase the longevity of the lifespan.
Finally, I want the feedback and closing remarks by Dr. Gayathri. Ma'am?
Yes, I agree with all my co-panelists. We need an awareness from the patient perspective. And also, I think the public awareness is required. Only then it will really work out. See, it's all, now everything is Dr. Google, Dr. WhatsApp also now. So I think we should have more awareness programs for the public so they know about the harmful effects of smoking, what smoking can do, and also what can be done to help people by these screening methodologies, and whom to approach if they have such issues. So all those things has to be highlighted. I think some public awareness programs in the clinics, some flyers, some pamphlets, all those things will really help. I think that is the need of the hour.
Thank you. Thank you all panelists. And I thank Dr. N.H. Krishna ji giving me an opportunity to moderate this. And Dr. Vijay has always been like a buddy to me, and I thank him as well because he's bringing in me again and again into the discussions and then the panels. And also I thank Dr. Anil Maske and Dr. Ashish Dubey ji and whole team. I've not known the names. I think I will do more times of this, and then I'll come to know the technical team guys' names and also as well. I thank them all. I think it was a wonderful discussion on a Diwali Eve night. I would put it like that, like Christmas Eve night, kind of that Diwali Eve night. Tomorrow is Diwali. Have wonderful Diwali, everyone. And then it was a wonderful discussion.
Yes, thank you so much, CCI. Thank you so much, Dr. Ravi, for moderating such an excellent manner and bringing us all on board and getting our opinions. Happy Diwali to all.
Happy Diwali.
Thank you, Dr. Rafi. It was wonderful.